Welcome. In this session, we'll be discussing about primary angle closure glaucoma. Primary angle closure is an anatomical configuration of the eye in which aqueous outflow through the iridotrabecular angle or the trabecular meshwork is obstructed by the peripheral iris in the absence of any ocular comorbidity which predisposes to closure of the angle. And this obstruction can be due to either an apposition or adhesion between the peripheral iris and the trabecular meshwork. In this photograph, we see the peripheral iris obstructing the access of the aqueous humor to the trabecular meshwork in the anterior chamber angle. Although angle closure glaucoma constitutes approximately 25% or 1/4 of all glaucoma patients globally, prevalence of blindness due to angle closure glaucoma is similar to the prevalence of blindness due to open angle glaucoma. But in some races, such as East Asians and Eskimos, the prevalence of angle closure glaucoma is actually more common than the prevalence of open angle glaucoma. Angle closure glaucoma and its high visual morbidity can be prevented by early recognition and treatment. Contrary to common perception, clinical course of primary angle closure disease can be either asymptomatic chronic angle closure or it may present with a symptomatic acute angle closure attack. And it is important to note that asymptomatic chronic angle closure is much more common than acute angle closure attack, and this is important to remember. Gonioscopy is required for diagnosis and assessment of primary angle closure disease. We have discussed gonioscopy technique, findings on gonioscopy, and grading of the anterior chamber angle in detail in a previous session. In this photograph, we see an open anterior chamber angle which is visible on gonioscopy, and in this photograph, gonioscopy shows angle closure in which the corneal wedge does not meet the slit on the iris. Gonioscopy should be done in all patients in whom the peripheral anterior chamber appears shallow by the von Hedig's technique on slit lamp examination, and this is very important to remember. We can differentiate between appositional and synechial angle closure by indentation gonioscopy with a 4-mirror gonio lens. If there is persistent angle closure or raised intraocular pressure following laser peripheral iridotomy or LPI, gonioscopy can help us to determine the cause of the persistent angle closure, and we'll be discussing these causes further in this session. And following treatment of all forms of primary angle closure glaucoma, gonioscopy is recommended at periodic intervals to detect further narrowing of the anterior chamber angle with age, which usually occurs due to increasing anteroposterior thickness of the crystalline lens. An ultrasound biomicroscopy can help in identifying the cause of angle closure, whether it is due to pupillary-block or Plateau-iris, and we have discussed ultrasound biomicroscopy in the session on anterior segment imaging. The most important risk factor for primary angle closure is anatomical predisposition of the eye to anterior chamber crowding, and there are several parameters which indicate anterior chamber crowding, many of which can be measured by the anterior segment OCT, which we have discussed in the session on anterior segment imaging. The parameters include shallow anterior chamber depth of less than 2.5 mm, short axial length, smaller anterior chamber area, anterior chamber volume, anterior chamber width, and trabecular iris space area, increased thickness, area, volume, and curvature of iris, increased thickness and anterior vaulting of the crystalline lens, and small corneal diameter with increased curvature. Primary angle closure occurs more commonly in hypermetropic eyes, but myopic patients can develop primary angle closure, and this has been found particularly in Asian population, as increased axial length causing myopia may occur without increased anterior chamber depth, thus maintaining the risk towards primary angle closure. Primary angle closure has a higher prevalence in East Asians and Inuits as compared to whites or blacks, and as we have already mentioned, primary angle closure is more common than primary open angle glaucoma in Asians and Inuits. Family history of angle closure predisposes an individual to angle closure, and primary angle closure occurs more commonly in females, but this sex predilection cannot be entirely explained by anatomical predisposition of the eye. Risk of primary angle closure in predisposed individuals increases with age, and this is associated with the increasing anteroposterior thickness and anterior vaulting of the crystalline lens. Certain factors are well known to precipitate an attack of acute angle closure, and they include dim illumination, emotional stress, particularly excruciating pain, and drugs. And both topical and systemic drugs can precipitate an acute angle closure attack. Topical mydriatics such as atropine, cyclopentolate, tropicamide, epinephrine, and phenylephrine can precipitate an attack of acute angle closure by dilating the pupil. And although topical myotics are known and are used to pull the peripheral iris away from the anterior chamber angle, thus opening the anterior chamber angle, but myotics such as stronger cholinesterase inhibitors, which are not so commonly used presently, can cause significant contraction of the ciliary body, relaxing the zonules, as a result of which the crystalline lens can move forward, increasing both the apposition between the iris and lens and shallowness of the anterior chamber, including the angle, and that is why gonioscopy needs to be repeated soon after these drugs are initiated. Systemic drugs with either sympathomimetic or anticholinergic activity can cause pupillary dilatation and precipitate an attack of acute angle closure, and these includes medications for allergy, cold, nausea, acidity, antispasmodics including bronchodilators, urinary antispasmodics and gastrointestinal antispasmodics, muscle relaxants, and CNS drugs including psychiatric medications such as selective serotonin reuptake inhibitors, tricyclic antidepressants and phenothiazines, antiparkinsonian drugs, appetite depressants, and CNS stimulants and hallucinogens. Pathogenetically, the iridotrabecular apposition in primary angle closure can result from either pupillary-block or Plateau-iris. Pupillary-block is the most common cause of primary angle closure, and Plateau-iris can contribute to angle closure in up to 1/3 of primary angle closure cases. In the pupillary-block mechanism, flow of aqueous from the posterior chamber to the anterior chamber through the pupil is blocked at the lens-iris interface, resulting in a pressure gradient between the posterior chamber and the anterior chamber, with the pressure of the aqueous in the posterior chamber being much higher than the pressure of the aqueous in the anterior chamber, as a result of which the mid-peripheral iris is pushed forwards, which results in blockage of the anterior chamber angle, and the blockage at the lens-iris interface is maximal in the mid-dilated stage of the pupil. In pupillary-block, the anterior chamber is deeper centrally than peripherally, and the anterior surface of the iris is bowed forwards. LPI is the definitive treatment for pupillary-block, and this is very important to remember. The LPI creates a passage for the aqueous from the posterior chamber to the anterior chamber, bypassing the block at the iris-lens interface, as a result of which the pressures in the posterior chamber and the anterior chamber equalize, the forward bulge of the iris is flattened, and access of the aqueous humor to the trabecular meshwork in the anterior chamber angle is re-established. The other mechanism for primary angle closure is Plateau-iris, and in Plateau-iris, the peripheral iris and not the pupil is the site of the blockage. In Plateau-iris, since there is no blockage at the lens-iris interface, aqueous flows normally from the posterior chamber to the anterior chamber through the pupil, but a forward indentation of the peripheral iris obstructs the access of the aqueous humor to the trabecular meshwork in the anterior chamber angle. Plateau-iris is a much less common cause of primary angle closure as compared to pupillary-block, and Plateau-iris is most commonly diagnosed only when the angle fails to open after pupillary-block is relieved by an LPI, and this is important to remember. As compared to pupillary-block, Plateau-iris is a more common cause of primary angle closure in younger individuals and myopic patients. The most important risk factor for Plateau-iris is anteriorly displaced ciliary processes which push the peripheral iris forwards, obstructing the angle. Other risk factors which can contribute to Plateau-iris is an anterior insertion of the iris on the ciliary body and a thick peripheral iris roll. And as in pupillary block, in Plateau-iris, pupillary dilatation further compromises the angle. In Plateau-iris, the anterior chamber depth appears normal centrally and the anterior surface of the iris appears flat in spite of a closed angle. And indentation gonioscopy shows a double hump configuration of the iris, the peripheral hump of the iris being created due to the forward pushing of the iris by the ciliary processes, and the central hump being created due to the forward pushing of the iris by the crystalline lens. And what is important is that indentation gonioscopy is required to elicit the double hump sign. So clinically, Plateau-iris diagnosis will be missed without gonioscopy. And since there is no blockage at the lens-iris interface in Plateau-iris, a patent LPI does not relieve the Plateau-iris configuration. However, an associated pupillary block is often present as a contributing factor to the primary angle closure. Two forms of Plateau-iris disease is known: Plateau-iris configuration and Plateau-iris syndrome. In Plateau-iris configuration, the intraocular pressure does not increase with pharmacological mydriasis in the presence of a patent LPI. But in Plateau-iris syndrome, IOP rises by more than 5 mm of mercury on pharmacological mydriasis in the presence of a patent LPI. And Plateau-iris syndrome is the most common cause of persistently narrow angle after LPI or lens extraction to relieve pupillary block. And in Plateau-iris syndrome, peripheral anterior synechia tends to start anteriorly at Schwalbe's line and proceed posteriorly, in contrast to pupillary block where peripheral anterior synechia progresses in a postero-anterior direction. Following diagnosis of Plateau-iris, LPI should be done to treat any associated pupillary block component, following which no further intervention is required if there is only Plateau-iris configuration. But if there is Plateau-iris syndrome, treatment options include chronic myotic therapy, which pulls the peripheral iris away from the anterior chamber angle, laser peripheral iridoplasty, which thins and flattens the peripheral iris, or lens extraction with endoscopic cyclophotocoagulation, targeting the anteriorly positioned ciliary processes. In iridoplasty, laser burns are applied on the peripheral iris, and it should be differentiated from laser iridotomy, in which a hole is made in the peripheral iris. So we'll first define the clinical types of primary angle closure and then describe them individually. As we have discussed, primary angle closure can be either an asymptomatic entity on presentation or can present as a symptomatic acute or subacute angle closure attack. And we have also mentioned that the majority of primary angle closure patients are asymptomatic, and this is very important to remember. Asymptomatic primary angle closure is described as a spectrum differentiated into three entities of progressive severity based on the natural history of the disease. And although this description is widely used in research, it does not mention the underlying cause of primary angle closure, whether pupillary block or Plateau-iris. The three entities in the asymptomatic PSC spectrum are primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. Primary angle closure suspect patients have more than 180 degrees of iridotrabecular contact, which is appositional, as a result of which the posterior trabecular meshwork is not visible for more than 180 degrees. Primary angle closure patients have, in addition to this appositional iridotrabecular contact for more than 180 degrees, peripheral anterior synechia or raised intraocular pressure. This photograph shows peripheral anterior synechia, and asymptomatic progressive peripheral anterior synechia is also known as creeping angle closure. Unless and until an LPI is performed in this situation, this creeping angle closure can progress in extent and can ultimately involve the entire angle. And primary angle closure glaucoma patients have, in addition to appositional iridotrabecular contact, peripheral anterior synechia and raised intraocular pressure, glaucomatous optic neuropathy, with characteristic optic nerve changes and visual field defects. And what is important to remember is that these characteristic optic nerve changes and visual field defects in primary angle closure glaucoma are similar to the findings in primary open angle glaucoma. Symptomatic primary angle closure occurs due to sudden blockage of most of the angle, and it can be either a subacute presentation or an acute presentation. When open angle mechanisms and angle closure mechanisms contribute to glaucoma simultaneously in an eye, it is said to be combined mechanism glaucoma. Angle closure mechanism implying obstruction of the access of aqueous to the trabecular meshwork by the peripheral iris, and open angle mechanism implying impaired outflow facility through the trabecular meshwork itself. Combined mechanism glaucoma can present as an angle closure developing progressively in an eye with pre-existing primary open angle glaucoma due to age-related increase in the anteroposterior thickness of the crystalline lens, or can present as raised intraocular pressure persisting with open angles after termination of an attack of acute primary angle closure and occurs due to trabecular damage during the attack. PACS patients who have more than 180 degree of iridotrabecular contact without peripheral anterior synechia and or raised intraocular pressure have a small risk of progressing to either primary angle closure or primary angle closure glaucoma, or having an attack of acute angle closure. And predicting this risk of progression by gonioscopic examination has been found to be unreliable. Historically provocative tests such as determining the rise in intraocular pressure after pharmacologic mydriasis or 15-minute dark room prone positioning were performed to predict the risk of progression, but these provocative tests had high false positive and high false negative results and were not always easily reversible. The Zhongshan angle closure prevention study showed no significant predictive power of the 15-minute dark room prone position test. Performing an LPI in a PACS patient is said to be reasonable but is not required for every patient. We should take into account narrowness of the angle, presence of symptoms, and patient's preference when considering LPI in PACS patients. But the patient should be counseled about symptoms of angle closure and the need for immediate treatment if these symptoms occur, and also about need for long-term follow-up because of the risk of progressive age-related narrowing of the angle with development of peripheral anterior synechia, raised intraocular pressure, and glaucomatous optic neuropathy. As we have mentioned, primary angle closure is the most common form of angle closure disease, and primary angle closure patients with peripheral anterior synechia and or raised intraocular pressure but without glaucomatous optic neuropathy should be treated. And there are two treatment options to open the anterior chamber angle along with medications to lower the intraocular pressure as required. The first treatment option to open the anterior chamber angle is LPI, which, as we have mentioned, relieves the pupillary-block and deepens the anterior chamber, thus reducing further progression of peripheral anterior synechia. But after LPI, the angle can again gradually and progressively narrow with time because of increase in the anteroposterior thickness of the crystalline lens, so repeat gonioscopy at periodic intervals is recommended following LPI. And in eyes with extensive peripheral anterior synechia, LPI can actually increase the IOP markedly because of the dispersed pigment and debris, and this raised intraocular pressure can be resistant to ocular hypotensive medications. The other option to open the anterior chamber angle is extraction of the crystalline lens, whether cataractous or not. And the EAGLE study showed that removal of the crystalline lens, even if clear or with non-visually significant cataract in angle closure eyes with intraocular pressure more than 30 mm of mercury, can actually be the preferred treatment, because as compared to LPI and medications, extraction of the crystalline lens provides lower IOP, lesser need for medications, and better quality of life, although the progression of visual fields is similar as with LPI and medications. And medications to lower the intraocular pressure will be required, If LPI or lens extraction fails to control the intraocular pressure, and in this situation, prostaglandin analogs, which increase uveoscleral outflow, are said to be particularly effective. PSEG patients have glaucomatous optic neuropathy in addition to peripheral anterior synechia and raised intraocular pressure, and glaucomatous optic neuropathy of PSEG has optic nerve head and visual field changes similar to POAG, and only by looking at the optic nerve head and the visual field report it is not possible to differentiate between these two entities because of the asymptomatic nature of PSEG resembling POAG, and these two entities can be differentiated only by gonioscopy. And this underlines the need for gonioscopy in all eyes with either shallow peripheral anterior chamber and or glaucomatous optic neuropathy, and this is very important to remember. So when we encounter an eye with either shallow peripheral anterior chamber and or glaucomatous optic neuropathy, we must do gonioscopy. And primary angle closure glaucoma is a major cause of blindness in Asians. And treatment options for PSEG are similar to the treatment options for PSC, with LPI being the initial treatment option along with medications to lower the intraocular pressure, with lens extraction having been shown to be a preferred treatment option in these situations in the EAGLE study. If these three treatment options do not control the intraocular pressure and glaucomatous optic neuropathy progresses, other treatment modalities need to be considered, such as trabeculectomy and valve implantation, which we will be discussing with acute angle closure. Subacute or intermittent angle closure is characterized by intermittent episodes of symptoms consisting of blurred vision, colored halos around light, eye pain and headache, and elevated intraocular pressure. Blurred vision and colored halos around light occur due to corneal edema, particularly corneal microcystic epithelial edema, and colored halos around a light source appear something like as shown in this photograph. These intermittent episodes typically occur in dim illumination, and the episodes usually resolve spontaneously, often after sleep-induced meiosis, and the intraocular pressure remains normal in between the episodes. This entity can be confused with headaches and migraine, and with multiple such episodes, peripheral anterior synechia develops and progresses in extent. And treatment of subacute angle closure is similar to primary angle closure, with LPI and or lens extraction and medications as required. Acute primary angle closure or APAC is caused by rapid and severe increase in intraocular pressure due to abrupt closure of most of the angle, and incidence of APAC has been estimated to vary from 5 to 10 per 100,000 people per year. And if we compare this with the prevalence of asymptomatic primary angle closure, approximately 1 in 1,000 individuals with asymptomatic primary angle closure develop acute primary angle closure attacks per year. Symptoms of acute primary angle closure attack includes ocular pain and headache, usually severe, along the distribution of the fifth cranial nerve. Blurred vision occurs due to corneal epithelial edema as well as ischemia of the optic nerve head. Patient can perceive colored halos around light due to corneal epithelial edema, and systemic symptoms like nausea, vomiting or sweating, and bradycardia or arrhythmia can occur. Signs during an attack of acute primary angle closure include conjunctival and episcleral congestion, the conjunctival congestion being both ciliary and peripheral, corneal edema, mostly microcystic epithelial edema, contour of the anterior chamber and iris, which we have already mentioned, but which we will discuss again because it is so very important. In pupillary-block, as shown here in this diagram, the anterior chamber is overall shallow, with its central portion being relatively deeper than its peripheral portion, and the contour of the iris shows a forward bulge of its mid-peripheral portion. In acute primary angle closure attacks solely due to Plateau-iris, which occurs rarely, the anterior chamber, as shown here in this diagram, has a normal depth centrally, and the contour of the iris is flat. In malignant glaucoma, which does not belong to primary angle closure but whose anterior chamber and iris contour must be differentiated from that of pupillary-block and Plateau-iris, the entire anterior chamber is almost equally shallow, and there is forward bulging of the entire iris. And this clinical differentiation between these three entities is very important to understand and remember. In acute primary angle closure attack, the pupil is mid-dilated and irregular in shape and is either sluggish or non-reacting to light, and this is due to IOP-induced ischemia of the pupil sphincter muscle. When measured, the intraocular pressure will be found to be severely elevated and there can be mild anterior chamber reaction, and we can detect shallow anterior chamber even without the slit lamp by using a pen light and projecting the light from the temporal aspect. And if the anterior chamber is severely shallow, the nasal aspect of the iris will remain dark and will not be illuminated by the light projected from the temporal aspect of the eye. Gonioscopy is required for definitive diagnosis of APAC, but since there is corneal edema, the cornea needs to be cleared before gonioscopy can be performed, and this can be done with either ocular hypotensives or application of topical glycerin. Topical glycerin application must be preceded by application of topical anesthetic, otherwise application of glycerin on the eye is painful. Performing dynamic gonioscopy may be able to break the attack of angle closure, as we will be discussing further, and gonioscopy of the other eye is very important and reveals some degree of angle closure in the other eye. If the contralateral eye has open angles, other causes of angle closure should be considered for the eye having an attack of acute angle closure. Acute primary angle closure is an ophthalmic emergency which requires urgent treatment in the form of lowering of intraocular pressure, breaking the attack by opening at least some portion of the anterior chamber angle so as to allow some aqueous to drain through the anterior chamber angle, followed by definitive treatment for the underlying cause to prevent further attacks. And as we have discussed, the underlying cause is usually pupillary-block, and in some cases Plateau-iris contributes to angle closure. Medications used to lower intraocular pressure in an acute primary angle closure attack include topical beta blockers, alpha-2 adrenergic agonists or carbonic anhydrase inhibitors. Systemic carbonic anhydrase inhibitors, mannitol or glycerol can also be used additionally, but prostaglandin analogues are not useful in the acute setting because of their delayed onset of action. And non-selective adrenergic agents such as apraclonidine should be avoided as they may cause pupillary dilatation, increasing the pupillary block, and also may increase iris ischemia. An attempt should be made to break the attack by opening at least a portion of the closed anterior chamber angle so as to allow aqueous to exit the eye through the anterior chamber angle, and this can be done either mechanically by indentation gonioscopy or globe compression of the central cornea or with cholinergic agonists, and this compression should be done every 30 seconds. However, this compression can be painful in a tender eye and may cause further rise in intraocular pressure. Cholinergic agonists such as pilocarpine 1 to 2% can be tried to break the attack of a mild acute primary angle closure. Pilocarpine causes miosis, thus pulling the peripheral iris away from the angle, and in doing so attempts to open the closed angle. Pilocarpine also facilitates performance of LPI by stretching and thinning the iris. But pilocarpine does not work with very high intraocular pressure because very high intraocular pressure causes ischemia of the sphincter muscle, which no longer responds to pilocarpine. And as we have noted earlier, cholinergic agonists may worsen angle closure by moving the crystalline lens forward, and this occurs particularly with stronger cholinergics such as cholinesterase inhibitors, and these drugs should be avoided in this situation. Some studies have suggested that laser iridoplasty can be used as an alternative to break the attack of acute primary angle closure. And unlike creation of an LPI which requires a clear cornea, Iridoplasty can be performed through a relatively hazy cornea. And as with asymptomatic primary angle closure, definitive treatment of an attack of acute primary angle closure so as to prevent recurrence of the attack is LPI. But as we have mentioned, performance of an LPI requires a clear cornea for which the intraocular pressure has to be lowered, or otherwise topical glycerin has to be instilled preceded by topical anesthetic. Failure of LPI to open the angle or to reduce the intraocular pressure suggests one of the following possibilities: Plateau-iris syndrome, extensive peripheral anterior synechia, combined mechanism glaucoma, or secondary mechanisms of angle closure. And these are very important to remember in clinical practice. If LPI does not open the angle, laser iridoplasty is the next recommended treatment. Surgery for acute primary angle closure attack is indicated when there is inadequate opening of the angles and or lowering of the intraocular pressure with medical and laser therapy, or if the patient is intolerant to medication or is not able to cooperate during laser. And options for surgical treatment include iridectomy, lens extraction when the swollen lens appears to be the primary cause of pupillary-block, but this procedure can be complicated by presence of hazy cornea, inflammation, shallow chamber, high intraocular pressure, floppy iris, subluxation of lens, and high incidence of malignant glaucoma when lens extraction is attempted in a patient having an acute primary angle closure attack. And malignant glaucoma has even been reported following LPI. Other surgical procedures include goniosynechial lysis, which is usually done along with lens extraction when there is extensive peripheral anterior synechia. Trabeculectomy has a low success rate in inflamed eyes with a high risk of malignant glaucoma, and valve implantation is a consideration following failed trabeculectomy or when the risk of trabeculectomy failure is high. And cyclodestruction is the last option in painful eyes with poor visual potential. Following a successful treatment with LPI to open the angle and lower the intraocular pressure, which occurs in most cases of acute primary angle closure attack, gonioscopy must be performed after resolution of the attack. Gonioscopy must again be performed to ascertain that the angles are adequately open, because IOP itself is not a reliable indicator. Because ciliary body ischemia can occur due to the raised intraocular pressure during the attack, and this ciliary body ischemia can persist, resulting in low intraocular pressure for several weeks following the attack, even if the angles are inadequately open. And this is why gonioscopy is so important after resolution of an attack of acute primary angle closure. And when there is low IOP due to ciliary body ischemia, after several weeks following the attack, the IOP increases again if the angles are not adequately open. So gonioscopy and IOP measurement should be repeated at periodic intervals following an attack of acute primary angle closure. As we have mentioned previously, with an attack of acute primary angle closure in the first eye, gonioscopy of the second eye usually reveals some degree of angle closure. And in this situation, LPI of the second eye is recommended so as to prevent such an attack in the second eye, and this is very important to remember. Topical steroids are given for a week to control inflammation following LPI, and topical ocular hypotensives are given as required. And with angle closure, prostaglandin analogs may be particularly effective as it increases outflow facility through the uveoscleral route. So prostaglandin analogs are not useful during the acute stage of the attack, but are particularly effective in long-term control of intraocular pressure in eyes with primary angle closure. Sequelae of an attack of acute primary angle closure include IOP-induced mechanical glaucomatous optic neuropathy, vascular ischemic optic neuropathy, retinal vascular occlusion such as CRVO, fixed and dilated pupil, sectoral iris atrophy with pigment dusting of the corneal endothelium, Glaucoma flecken, which are small white anterior subcapsular lenticular opacities in the pupillary area, as seen here in this photograph, and they are a sign of previous episode of raised intraocular pressure and corneal endothelial cell loss. Formation and progression of peripheral anterior synechia is also a sequela of an attack of acute primary angle closure, and peripheral anterior synechia following an attack of acute primary angle closure is broad-based, tends to occur in the superior quadrant where the angle is narrowest, with the severity of the extent of peripheral anterior synechia correlating with the duration of the attack. Differential diagnosis of primary angle closure include secondary angle closure and other causes of headache such as migraine and cluster headache. In the asymptomatic PAC spectrum, a study from Greenland reported that 16% of PACS patients converted to PAC, PACG or APAC in 10 years' time, and a study from India reported that even after LPI, 28% of PAC patients converted to PACG in 5 years' time. And among patients with symptomatic angle closure glaucoma, 75% of those with an attack of acute primary angle closure can be treated with LPI alone, and need for additional procedures increase with longer duration of acute primary angle closure attack and history of intermittent symptomatic episodes prior to presentation. To recap the salient points, primary angle closure occurs due to obstruction of aqueous drainage through the trabecular meshwork by the peripheral iris in the absence of any ocular comorbidity. Risk factors for primary angle closure include older age, female sex, race, ocular biometrics, and hypermetropia. Angle closure due to Plateau-iris can actually occur at a younger age and in myopes. The most common mechanism of primary angle closure is pupillary-block. Much less commonly, Plateau-iris can contribute to primary angle closure glaucoma. Pupillary-block occurs when passage of aqueous from the posterior to the anterior chamber is blocked at the pupil, resulting in increased pressure in the posterior chamber relative to the anterior chamber, which leads to forward bulging of the mid-peripheral iris called iris bombae, which in turn blocks access of the aqueous to the angle. This can be relieved by a laser peripheral iridotomy or LPI, which by bypassing the pupil equalizes the pressure in the posterior and anterior chambers, flattening the forward bulge of the iris and opening the angle. Plateau-iris occurs due to anterior position of the ciliary processes, pushing the peripheral iris forwards towards the angle. LPI cannot relieve angle closure due to Plateau-iris, and Plateau-iris is usually initially suspected when LPI fails to open the angle in a patient diagnosed to have pupillary-block angle closure. Treatment for Plateau-iris is laser iridoplasty. Slit lamp examination in pupillary-block shows an overall shallow anterior chamber which is relatively deeper centrally than peripherally, with forward bulging of the mid-peripheral iris. In Plateau-iris, the central anterior chamber appears normal in depth with shallowing of the peripheral anterior chamber and a flat anterior surface of the iris. In malignant glaucoma, which we will be discussing in a subsequent session, the entire anterior chamber, both its central and peripheral portions, appear almost equally shallow. Gonioscopy should be done in all individuals with a shallow peripheral anterior chamber. It helps in assessing the extent and degree of angle closure, in differentiating between appositional and synechial angle closure, in diagnosing causes of failure of LPI, and to detect progressive angle narrowing over time following successful LPI. Primary angle closure can be asymptomatic or symptomatic. Asymptomatic primary angle closure has been described as a spectrum whose stages are primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. Symptomatic primary angle closure can be subacute or acute. Asymptomatic primary angle closure is much more common than symptomatic primary angle closure. Primary angle closure suspect patients can be treated with LPI depending on the severity of angle closure and patient's preference. PAC and PACG should be treated by LPI or lens extraction and ocular hypotensive medications as required. Prostaglandin analogs are particularly effective in angle closure glaucoma. Subacute primary angle closure presents with intermittent episodes of angle closure with symptoms of blurred vision, colored halos around light, and headache, which spontaneously remit particularly after sleep-induced miosis. Subacute primary angle closure is treated by LPI or lens extraction and with ocular hypotensive medications as required. Acute primary angle closure presents with sudden onset of severe ocular pain, blurred vision, colored halos around light, severe headache, nausea, vomiting, sweating, and bradycardia. Signs include conjunctival congestion, cloudy cornea with microcystic corneal edema, very shallow peripheral anterior chamber, sluggish and non-reacting mid-dilated pupil, and a very high intraocular pressure. Factors which can precipitate an acute or subacute attack of angle closure include dim illumination, emotional upset, and drugs. Acute primary angle closure attack is a medical emergency. Treatment includes lowering of the intraocular pressure, breaking the attack, and definitive treatment with LPI so as to prevent recurrence of a similar attack in the future. LPI requires a clear cornea, which usually occurs after lowering of the intraocular pressure. Otherwise, topical glycerin has to be used to clear the cornea to perform an LPI. LPI of the contralateral asymptomatic eye is very important. If LPI is not possible or does not work, other treatment modalities which can be employed to lower the intraocular pressure include surgical iridectomy, cataract extraction with goniosynechial lysis, aqueous drainage surgery, or cyclodestruction. Causes of failure of an LPI to open the angle and or reduce intraocular pressure include Plateau-iris, extensive peripheral anterior synechia, combined mechanism glaucoma, and secondary angle closure glaucoma. Sequelae of acute angle closure attack include ischemic and glaucomatous optic neuropathy, retinal venous occlusions, sectoral iris atrophy, fixed and dilated pupil, peripheral anterior synechia, and glaucom flecken. Thank you for listening.